It will, hopefully. Hello! How do you know if people can hear us now?
I don't know, it still says loading for me on the live section.
This is live. Okay.
I don't know that it is. Hang on. I think I've disconnected.
How about this? If people can hear us, put something on the chat. Anna, can you hear us?
Oh, I can hear you, yeah.
Oh, great! Sorry, we didn't open up the presentation the most smoothest. Hi, everyone. Thank you. Yes. Thank you for those of you that replied on the chat. Welcome to our Past the PSA series. I will...
Brilliant. Can we have the slides shared, James? Perfect. Oh, that's creepy.
There you go.
Okay, perfect. We'll make a start, other people can filter in. So hello and welcome to our PSA series. Intro to the PSA is what we're going to cover today. So we're going to talk about the exam format, tips that we have, and a little bit of different question types. My name's Tass. I'm a foundation doctor in Sussex, and Julie is working at Royal Berkshire Hospital. If we go to the next slide. So this will be a 4-part series where we're going to cover all the different sections of the PSA. It won't just be us. There's different F1s that will be doing some of the teaching too. And we are supported by Health Education England. Later on, in the spring, we'll also be having the Thursday 15 sessions that were on last year. These will be weekly sessions covering a variety of specialities and topics to help you prepare for finals if you have summer finals. If you follow all of our social media, you'll be kept up to date with that. But let's focus on the PSA today. So next slide. So this is just a little overview of what the PSA includes. So it's a 2-hour exam with 60 questions that are broken up into different types of questions. I've stolen this graphic from the PSA's website. Basically, you're going to have some prescribing, some reviews of prescriptions, planning management, information giving, calculations. You can look at drug monitoring and adverse drug reactions, and then some data interpretation at the end, and it will cover a wide variety of specialities to prepare you for F1. It's quite a time pressured exam. So you have 120 minutes to do 60 questions. And key to success is good time management and efficient use of the BNF, which we're going to go over today. There's no negative marking, so if you really don't know an answer or you're running out of time, you can just click some of those multiple choice questions at the end, just so you have a chance of getting it right. Practice makes perfect as well, so there are past papers online. Your university will probably provide you some practice papers, and QuesMed also has really good resources. It's all computer-based, so if we're thinking about sort of practical tips for the exam, make sure you've activated your account before you turn up and you know your password. You'll also need your ID and a pen if you want to make any notes, especially for the calculation questions. If we go to the next slide. So although there are 60 questions and 120 minutes, it's not just sort of 2 minutes per question, because some questions are worth a lot more than others. So if you just click next, it will show you which each section is. If we just click next. Perfect. So you can see here in yellow, the prescribing section, although it's only 8 questions, actually makes up 40% of the marks. So you need to spend a lot longer on those questions than, say, the data interpretation at the very end. If we go next. So this is our sort of suggestions for how you might break down the timings. You do what works for you, but this is our suggestion, and basically you just move on in the exam, and if you've got any time at the end, you can come back and review any questions that you've flagged. You can screenshot this now while we've got it up, but you will get the the sort of slides, I think, at the end. So just give everyone a second to screenshot it, if that's okay. Perfect. So I actually use these timings in my practice papers as well, because it is really more time pressured than you'd imagine it would be. I think we've gone one slide ahead. There should be one that says prescribing. Yeah, perfect. So section 1, prescribing, is the highest sort of meatiest section. You'll be asked to prescribe for common, acute and chronic conditions, also pain management, fluids, and as well as these high yield topics that I've put in the little bubbles, you'll need to do common things like antidepressants, antihypertensives, contraceptives, inhalers, bisphosphonates, etc. So it's important to do lots of practice papers to think about these questions. And you get 5 points for the correct drug and 5 for like the correct way to prescribe it. So the dose, the route, the frequency. So it's really important to use the BNF carefully. Okay. I've popped go back 1 second. I've popped an example question on here. It's just from the PSA website where they show you the question format. This is the layout you will see on the sort of computer-based examination. Be really careful when you're prescribing. They might include in the STEM any contraindications. They might have a renal or liver impairment, or it might be a woman of childbearing age and that the medication isn't suitable for them. Check for allergy status and any interactions with their sort of current drugs. Okay, so if we move on, prescription review. So this is 8 questions again, but they are sort of 2 parts, A and B, and you just click the drugs that you think are the answer in each column for A and B. They will ask you either for 1 or 2 ticks per column. So examples of sort of drug-drug interactions that you might see are things like warfarin and clarithromycin. And you can use the Medicines Complete Interaction Checker for this because you won't have the phone app BNF, unfortunately. And it's important to learn common side effects of drugs so that you don't have to keep checking, for example, that ACE inhibitors cause a dry cough. So it can really help if you have in your head a list of common side effects and interactions. If it's an obvious answer, great, click it and move on. If not, I used to start with checking for any interactions and then checking any medications I wasn't sure about against the BNF to see if they've made any mistakes. It can take a long time, so if you're getting really stuck, I would flag it, maybe click some options just so you don't lose like 0 marks, and then just move on and come back at the end if you have time. Okay, so if we move on to so these sections are now much sort of smaller points wise. These ones are worth only 2 marks each. So we suggest doing about a minute per question. In planning management, you'll be given a STEM, a question, and then 5 choices to choose from. I would recommend reading the question first so you know what you're looking for when you read the STEM. And then the options might include different prescription options, non-drug options, and also not doing anything, which might be the valid option. So just read the options carefully. Don't click on the first one you see. Okay, moving on. So providing information. This is all about what would you communicate to a patient. Sometimes there might be more than one correct answer, but it's about what's the most important for that patient. So you can look in the BNF in the patient care advice and in the contraindications side effect sections. And if there's like a safety warning, that's usually something very important to mention to the patient. If we move on to calculation skills. I personally like the calculation skills section, but it's kind of like a love-hate thing for most people. If you don't like it, or even if you know you feel quite confident in the section, do practice it because it can be a good way to boost your marks later on in the exam. But like the other sections, don't agonize over it. There are other sections to come. Move on if you're stuck. I've just put in green, I've put a little box about the sort of what 1% means and what 1 in 1,000% means. It can be in the heat of the exam quite confusing doing your unit conversions and your orders of magnitude, so be very careful with that. And I actually wrote down every single step on paper just to make sure I wasn't making a mistake. There is an on-screen calculator provided in the exam, but I would recommend bringing your own one. It's much quicker to use, but it can't be a scientific one. It needs to be the really simple ones you get in primary school. Okay, so if we go to the next slide, adverse drug reactions. So I've just popped the free example that's on the PSA website here. It's again multiple choice. Just choose one option from the 5 and you get 2 marks for the right choice. So if you really don't know, just choose one. You might be asked to identify the reaction that's happening or the cause of the reaction, whether that's the specific medication or a drug-drug interaction, or as you see in this example, you might be asked to manage a drug reaction. Okay. If we move on, nearly at the end of the different question types. So drug monitoring. Again, this is just 2 mark questions, so we suggest a minute per question, and you choose the right option from 5. This is where it's useful to know common monitoring requirements for drugs that need monitoring. But it's not just about monitoring for harmful side effects. So, for example, furosemide, you'd be checking the kidney function to check for harmful side effects. You're also monitoring the benefit for some drugs. Furosemide, you might be asked to, you might be monitoring the daily weights to see if it's working. So be really careful with the question. Are they asking you about monitoring for the benefits or the harms? Okay, because they can try and catch you out there. And then data interpretation is the last section. It's also my least favourite section, if I'm honest. I ran out of time anyway and just clicked some random questions in the real exam, and that will happen. Time will fly by, and if there's a couple of trickier questions earlier on, you may just run out of time. So prioritise the sections that you know you're good at from practicing, and then you can sort of get the marks in those sections you're good at. You'll be given a clinical scenario here and some sort of data to interpret, whether that's a blood test or a graph like a paracetamol curve. And then you'll be asked to decide an action to take based on that. That might be stopping or increasing the dose of something, or what did I say? Reducing or increasing the dose, stopping something completely, changing to a different medication, or you might be asked to just not do anything. Okay. So if you like this section, maybe come to this first and then go back to a section that you don't like as much, because there is a chance you may run out of time. I'm going to hand over to Julie now, who's going to give us amazing top tips for using the BNF in the most efficient manner possible.
Great. Hi everyone. So I'm just going to run through top tips for using the BNF, because essentially the PSA is just a big old exam on how to use the BNF. I would recommend in the lead up to the PSA really getting to know the BNF and or Medicines Complete, which is the other kind of prescription book that you can use if you want. I personally use the BNF, and I think most of my other med school friends use the BNF as well. I would recommend that perhaps in the lead up to the exam, kind of just using it every day during placement, during exam revision, wherever you might be thinking of prescribing a drug or thinking about a drug when you're on placement, just to get familiar with where things are, how it works, and just get used to using the treatment summaries and the interaction checkers. And I'll run through some tips. So these are the drug monographs. So I've just put up an example of ramipril there, and I've highlighted the ones that I think are the sections of each drug monograph that you'll probably use the most. You'll be using the indications and dose, contraindications, all of that, and more of those sections you'll use. They'll be more relevant to the certain types of questions that we'll have. I would recommend that, I think, as soon as you open up the PSA, get the BNF up and all Medicines Complete and start to split screen. So that way, when you need to use it, you can just immediately scroll over to the BNF and click exactly what you need, and use Control F as well, because that will be your best friend when it comes to the PSA as well. So if we go to the next slide. I'll just quickly talk about the interactions checker. So like I said before, Medicines Complete is also available for you to use. Unfortunately, I can't access the Medicines Complete anymore because I'm not at uni, so I wasn't able to screenshot what the interactions checker or Medicines Complete looks like exactly, but it is there for you to use. I've heard from other people that some people prefer Medicines Complete. It has a bit of a cleaner interface, but obviously it's not as familiar as the BNF, especially if you're used to using the BNF for most of the time. So when it comes to this, it's really your personal preference. Just try both of them out when you're revising for the PSA or doing exam papers. Try using both of them, see which one feels the most natural and the most comfortable for you, and then stick with that. I know some people used both during the exam, so they used the BNF for all of the drug indications and all of the information, but then also had Medicines Complete open just for the interactions checker, because some people preferred the interactions checker. So whatever you do, just go with what you feel is the most natural, and make sure that when you open up your exam to have all of everything open and split screen so that you can click and find things as easily and as quickly as possible. So if you move on to the next slide. As most of you know, the treatment summaries are available for you to use through the BNF. So these will have various kind of information and guidance based on different indications, different diseases. If we go on to the next slide, you'll see these ones that I think are perhaps the most relevant for the PSA. You can screenshot these if you like. These are the treatment summaries that I would suggest you get really familiar with in the lead up to the exam. Have a look through, read through, see what information is there in those treatment summaries and what information isn't there. There is a lot of things in the BNF that you might not know is actually there for you that you can use during the PSA. For example, the oral anticoagulation treatment summaries, where you'll find all of the things about warfarin and INRs and what to do if your INR is too high or low. And similarly, in poisoning and emergency treatment summary, you'll find things about what to give if someone has a paracetamol overdose, and also if someone is having maybe a reaction to their psychiatric drug. So I'd really recommend just taking a look through all of these treatment summaries and seeing what's there, as it will definitely help when it comes to the PSA. And if we move on to the next slide. So this is just more specifically about the prescribing and palliative care treatment summary. And I've just put this up for you here because I think it's probably one of the most useful things that you can have during your exam. So I've just screenshotted two of the tables that are on there, and that's just the opioid conversion tables that are there for you to use. There is also information there on how to switch between oral morphine to patches, which is a very classic PSA question. It might be worth remembering the basic kind of conversion, so kind of oromorph to morphine, that sort of thing, just so that you can do it quickly without having to look at this table during the exam. But if you get stuck or your mind blanks, then you know that these are there for you. And importantly, you won't find it if you just type in morphine on BNF. It will be under the prescribing and palliative care treatment summary. So if you move on as well, if you don't mind. So I just wanted to show you this quick little tip that someone showed me whilst I was revising for the PSA. I don't know if you're able to I don't know how well the screen is there for you to see, but if you look at the search bar on top of the screenshot, you can see that there's a little and or bracket thing that you can do. So this is a tip for your prescription review / adverse drug reaction questions. So if a question is asking you to compare information between multiple drugs, for example, if the question is what drugs out of this patient's list would cause them muscle cramps, you could type in muscle cramps and then in capital letters and then open bracket and then type in each drug, and then in between each drug if you put or, the BNF will automatically kind of filter the word muscle cramp against all of those drug monographs, and then whatever comes up will be the drug that contains that word muscle cramps. So for example, you can see when I've typed in muscle cramps and all of those drugs there, the results come up as amlodipine, which is the correct answer. And if you open up amlodipine, you will see that muscle cramps is under side effects, and that isn't there for any of those other drugs. I would also just an extra double check, because you don't want to lose points, just click on the drug when that comes up, and just make sure that it is under the correct section that you're looking for, so that it is under side effects and not under indication or something. And then I've just kind of run through, I'm sorry if this is going too quickly, but I've just kind of run through specific tips for each section of the BNF as well. So for the prescribing question, double check, because this is, like Tess said, the section that comes with the most points, and so you should probably allocate yourself the most time to do that as well. Just double check everything with the BNF. I think that there's enough time to do that, even if you're absolutely certain you just don't want to have missed something really small, or accidentally misread the question and get something wrong and miss out on potentially 10 marks. And then when you're prescribing specific doses, double check the indication. So for a certain drug, there might be several doses depending on the indication. So just make sure which dose that you're prescribing and if it's for the correct thing. And also with the patient's kind of details, check cautions and contraindications underneath that drug monograph. Check it against that patient's past medical history or any abnormal investigation test results that they give you. A lot of the time, the PSA might try and confuse you and give you unnecessary information that you don't need, but sometimes it might actually be information that you need. So definitely it's worth reading the patient blurb completely and taking into account all of the information that they give you. And then the prescription review, like Tess said, it's basically just to spot the error. So it means that maybe perhaps there's been an error in the timing of the drug, the frequency, the route, the dose, or the units. And this is where it's really useful to use the BNF. You can use that or tip that I mentioned earlier, or just use the search bar for BNF like a search engine. I know I did. And for planning management, it's more about using the relevant treatment summaries and finding the keywords as quickly as possible. And so this is where split screening and control Fing, all of your keywords will be very useful. So if we move on to the next slide. Oh, there you go. So providing information, the most important subsections of the drug monograph will be the ones that I've put there. So the important safety information, patient information and care advice, and directions for administration. So this section, you will have to read the patient brief clearly, and then also use your clinical judgment as to what you think is perhaps the most important piece of information that will be that particular patient will want. So it won't be that they'll want every single drug monitoring. It will point to something specific, and that will be reflected in the answers that you have offered to you. And with the calculation skills, like Tess said earlier as well, be very careful with your units. And I also wrote down every single step of my calculations. I think this is useful in case you've gone wrong somewhere. You can always see where exactly you've gone wrong and spend less time trying to correct that mistake. And with drug monitoring, kind of self-explanatory, the most important section of the BNF will be the monitoring requirements subsection. And with data interpretation, the treatment summaries might come in useful. Like I mentioned, the warfarin section is under oral anticoagulation. And again, just control F for any keywords, but it will mostly probably come from your own knowledge and the data interpretation. So that's just a very quick run through of the BNF. The other kind of tip is I don't know how many of you have the paper BNF available to you. It might be that you've bought it or have it in your library. This can be useful for you to have during the exam. So I think I personally didn't use it, but I know that Tess did. So I think there is a section at the very back of the BNF that has a big old list of all the common drugs and all of the common side effects that they cause. So you can, if you're able to bring it in with you, it might be useful to just have that one page just open in front of you, just for you to scroll through if you're getting a bit overdone with the screens, and if that would be useful for you. So again, it might be worth just you having a flick through the paper BNF, seeing if there's any really useful pages for you, and then bringing it in with you if you want. I think there was also some mention of, back in the day / last year, I think you're allowed to make minimal notes on the BNF. So that could be anything that you're really struggling to remember, like the maintenance fluid requirements for a person, or anything to do with timing, whatever you think might be useful. I believe that you were allowed to do that last year. I will double check with your with your med school, if that is allowed for you this year as well. But that might be particularly useful for you. And then if we move on to the next slide, I've just put in a couple of resources that I found useful whilst I was doing the PSA. So the Pass the PSA book is about £20 on Amazon. I found it really, really helpful. I ran through the past papers in there about 2 to 3 times each. Also, you have the actual prescribing safety assessment question banks themselves with lots of mock papers. I did those quite a lot as well and repeated each exam paper about twice as well. And then the other thing that I used that I got from a friend was these at a glance books. So there's a textbook and a workbook with loads of questions and answers that I did as well. The main kind of take home message of the PSA is just practice makes perfect. So just practice with whatever question banks you have available to you, and practice with friends and things like that. So we'll run through questions next. We've done one question for each section of the PSA just to give you an overall feel of what the exam is like. I don't know whether you would like to go through the realistic timings per each question, or we can just do a blanket, give you a few minutes for each section. If you want to pop up on the chat and say whether you want realistic timings or just generic timings per each question.
The questions are on the PowerPoint. Can we have it back? Sorry.
No.
Sorry, that's...
Oh, no one said anything. Well, we have half an hour, so we could do like, what's maths?
Someone has said.
Oh, realistic, please. Okay, should we go with realistic? So I think that means we'll just get the timer up on our phones.
Yeah.
So if you don't have it open already, get the BNF or Medicines Complete open in front of you. And if you have a calculator, whether it's on your phone, just in preparation for the calculation skills, and some pen and paper. And don't worry too much if you get slightly overwhelmed by the questions. The rest of our series will go through each section in more detail to help you. And this is just to give you an idea and a feel of what the PSA is like.
Absolutely. I think we said in the advertising that this session would be a bit more like with calculation questions, but we're going to focus on that slightly more in session 2 along with prescribing, because we thought it was important to give everyone a flavour of the types of questions that there are.
Tess, can I leave it to you to do the timing?
Yeah, so the first question, the prescribing one, will give about 5.5 minutes too. And then the other ones are all a lot shorter. So we'll do probably
minute and a half.
2 minutes 15 for the prescription review, and then about 1 minute per the other questions. But we will obviously go through the answers, so nobody panic if you haven't got there. This will sort of show you really how tight the timing is in the real thing.
Okay. Cool. So we will time and we will move on to the next question when the timing is done.
Yeah, we'll just say, move on, please.
Yes. So shall we start now?
Yeah.
So James, if you don't mind moving. Thank you. Okay, so we've got less than a minute left on this first prescribing question, and we'll move on to the next one very shortly. And if people just write down their answers for each question on paper, when we run through the answers, we will ask you to pop them in the chat.
Okay, so if we move on to the next one now.
So we'll give about two and a bit minutes for this question.
Okay, so we're going to give you just 1 minute for the next question, but don't worry because we will go over ways to know the answers in a bit. So if we, perfect. Okay, if we move on to the next question, also 1 minute. Okay, and then on to the next question. This is 1 minute 15. Okay, and then on to the next question. 1 minute. On to the next question, also a minute long. And then on to the last question, also a minute. Okay, so move on. Okay, so everyone take a breather. That's quite fast paced, especially towards the end. Well done if you wrote anything down. We're going to go through the answers one by one, and it would really help us if people could throw ideas into the chat section. It's completely fine if it's wrong. That's the whole point. If we thought you'd get every single question right, there'd be no point in having this talk. So go back. Okay, well, you've seen this now. It's fine. We can show the answer. So we'll go through the first prescribing question. Does anyone want to put, since we've gone back a slide, their ideas into the chat? What did people write? So what drug did people go for? And what dosing and frequency did they go for? You can just put what you saw flash up on the screen. Okay, someone suggested flucloxacillin, IV. One person said 1 gram, another person said it's 2 gram, QDS, or every 6 hours, which is the same if I'm right. Yeah, lots of flucloxacillin. QDS, yeah, okay, yeah, lovely. Okay, so we won't put the question back up because we'd have to go back, but basically it said write a prescription for one IV, so intravenous drug, that is most appropriate to treat the cellulitis. So for those of you that put IV, already we've got the route correct. But if you put flucloxacillin and then you put oral, you'd still get the 5 points for having the right drug. So if we press next, perfect. So basically I went into the BNF treatment summary for, I think, skin infections or something like that, and you go to the cellulitis section, and it shows you that the first choice for oral or IV is flucloxacillin, and if they're penicillin allergic, you can go clarithromycin or erythromycin or doxycycline, but in this patient I said no known drug allergies, NKDA, so we could just go for the fluclox. Obviously, if in the description it said the infection was near their eyes or nose, you'd need to go for coamoxiclav. And their creatinine clearance as well in the question was, I think, 45, so we didn't need to decrease it, but it's also always worth checking that there's no reason you need to adjust the dose, whether they're elderly or have renal impairment, etc. So once you click on flucloxacillin, you go to the indications, and it tells you by slow intravenous injection, you can give 1 to 2 grams every 6 hours. I think in the real thing, they give you a range of options. So you'd probably be marked correct if you put 1 gram or 2 gram. I went for 2 grams because of the CRP and the white cell count being very high. I wanted to make sure I was treating the infection adequately. But his news was 3, so 1 gram would also be very valid. Perfect. Okay, so don't click next, please. Can anybody put in the chat for the prescription review questions, which 2 medications did they think were most likely to cause the hyperkalemia in the prescription review question? So that was question A, was the 2 most likely to cause hyperkalemia, and then for question B within that, it was also which 2 are most likely to interact and cause harm. Okay. Has anyone got any suggestions that they thought for the prescription question? So someone suggested ramipril and cyclosporin as causes of hyperkalemia. Or everyone's suggesting those 2. Beautiful. Okay. And then what about ones that are most likely to interact and cause harm? Okay, so we've got 2 people suggesting the statin and the cyclosporin shouldn't be prescribed together. So if we press next, those are absolutely right. And we're going to now go over why. Let me just find my slides here. So the approach you can use for question A is you can just learn common causes of the different electrolyte imbalances, and I'm going to go over a few acronyms on the next slide. I also use the BNF paper version, but obviously someone has told me in the chat that you're not allowed that this year. Then there's Julie's and/or method that you can use in the sort of online BNF search function. However, often in the side effects, it just says electrolyte imbalance, and it doesn't say which electrolytes are most likely to be caused problems by that drug. I also found, though, in the interactions checker that ramipril, it actually says underneath it, ramipril and cyclosporin can increase the risk of hyperkalemia. So there might be some more information there if you're looking for it. For question B, I personally recommend the Medicines Complete interaction checker. You need an Open Athens login from your university, and then you just type all the medications that the patient is prescribed, and it will tell you if there's any interactions, whether they're severe or less severe. You can also manually check for each drug if there are interactions, but that takes a lot longer. And for common or severe interactions, it's helpful to learn them so that you're not wasting time looking for it in the exam. So if we go to the next slide, if we just pop the next slide on. Beautiful, thank you. So I've just sort of summarised some causes of hyper and hypokalemia on this page. I found this really useful for the PSA and also real life. So the 2 acronyms are DREAD, so that's for hyperkalemia because you're in a heightened state, so higher hyper. And then there's DIRE, a sort of depressed state for hypokalemia. And I've just put the sort of different reasons you can have these imbalances. And then for the hyperkalemia drug causes, doesn't really roll off the tongue, but I learnt the acronym HAT-C. Doesn't really make any sense, but that's how I learnt it. And it's just heparins, ACE inhibitors, tacrolimus, cyclosporin, which was in the question, and aldosterone antagonists, especially if you have like ACE inhibitors and like spironolactone or eplerenone together, and that can be a real cause of hyperkalemia. So you would always, before giving spironolactone or eplerenone, check the potassium before and then after starting treatment to see if it's had an effect. And if they do have a raised potassium, you need to hold it. Okay. If we go on to the next slide. So these are just some medications that can cause hyponatremia. That's also quite a common question in the exams. Quite easy to remember that the SSRIs, I think, and the ventroflumethiazide in particular. And then I've popped a few key interactions that I found in my notes here. So the macrolides, the statins, and then and azoles, antifungals basically interact with everything, and as does clarithromycin, to be honest. So if it's on a prescription review question, clarithromycin is probably a culprit. Perfect. Now, before we go to the next slide, for the planning management question, has anyone got any suggestions that they put for the most appropriate management option? So this was question 3. The options were sort of hold all the medications until the AKI had resolved, or don't make any changes, hold the metformin, hold the ramipril, or switch the metformin to insulin. What have people put in the chat? Okay, someone said they double checked the PSA website and it says you can still use the paper version. It sounds like you need to check with your unis whether or not they're allowing it, because it can be quite a useful tool. So we can try and get access to the interactions checker for next week so that we can show you guys. But basically it's just, you go on the Medicines Complete BNF, and in the search bar you just type in all the medications, and then down the side it offers that you can check the interactions. Okay, has anyone got any suggestions for the planning management question? What would they do for this patient that has an AKI? Someone suggested holding the Ramipril. Does everyone agree with Sophie? Well, I agree with Sophie. If we go to the next slide, absolutely hold the Ramipril. So the acronym I learned for AKI sort of drugs is DIAMOND. So stop all diuretics. Be very careful with iodine. Stop any ACE inhibitors or angiotensin receptor blockers. Those ones are all like sort of nephrotoxic. Then metformin is less about them that causing damage to the kidneys, but more about the fact that it's not it's going to cause a lactic acidosis. And same with the opiates. The kidneys aren't getting rid of it, so it's going to build up and you can get an opioid toxicity. So you need to be very careful with opioids. You can sort of switch to something like oxycodone if someone's got a very low renal function. Now, NSAIDs, it's supposed to say continue the cardioprotective aspirin dose. I'm not sure why that's cut off there. So if someone's on sort of 75 milligrams of aspirin a day, you might consider sort of continuing that. But if they're on a 300 milligram dose, you're probably going to stop that. And any other NSAIDs for pain relief, you're going to hold them while they've got the AKI. And then the last D in DIAMOND is disease-modifying medications. They've usually got a very narrow therapeutic range. You're at risk of them not working or a toxic level developing. So if you want to keep giving them, you need to closely monitor them. But it might be a case of stopping them. The reason we're not holding the metformin in this case is because the EGFR is still over 30. So if someone had a worse AKI, you might hold the metformin and that'd be a valid option. But here we can continue it because the EGFR is above 30. Okay. And then before we go on to the next slide, has anyone got any suggestions for the providing information question? So this was a question about a patient starting carbimazole for their hypothyroidism, and what's the most important information this patient should be given. People saying C, so sort of tell your GP if you get a sore throat or any other infective symptoms. Anyone disagreeing with C? Okay, so if we press next. So for carbimazole, when you click on the BNF, it has an important safety section, and it highlights 3 things that are very important, and it also has the same information as patient carer advice. So the safety information relevant to carbimazole is the neutropenia agranulocytosis, which I've got here. There's also an increased risk of congenital malformations. However, this patient is already on effective contraception. So although we would obviously tell the patient all of this, the most important thing here is the neutropenia and the risk of sort of bone marrow suppression. Okay. Option B, take before breakfast, is actually for levothyroxine, so for hypothyroidism. D is true. They will sort of measure to see if it's working, but it's not as important safety information as C. And E, I completely made up. On the safety information, there's also something about acute pancreatitis. It would be worth mentioning in real life to a patient, but the fact that in the patient care advice it only talks about the sore throat, mouth ulcers, etc., suggests that that's more important. And also this patient's never had acute pancreatitis, so that sort of last sentence about re-exposure and life-threatening acute pancreatitis is less likely. Okay. So I'm going to hand over to Julie for the next set of questions.
Yeah. So again, these are for the calculation question. So this was about the milligrams of sodium chloride that the patient would have received in 10 minutes. So if we can just pop into the chat what you think your answer was. Again, no worries if it was incorrect or if you're worried about it being incorrect. And we'll talk through the workings out and how I would have done it. Anyone? Oh. So Maymara said 1,500 milligrams. Anyone else agree or disagree? So we've got 1,200. I think that's enough variety to lead us to the answer. So if you don't mind, James, putting it onto the next slide. Can we have the next slide, please? Thank you. So the answer was 1,500. So I've just put my workings out on there. So it says that a 0.9% bag of saline is given. So you know that 0.9% will mean that they've had 9 milligrams in a mil. And the blurb says that she will have received 500 mils. So what I've done is 9 milligrams times 500, which gives you the total amount of milligrams of sodium chloride in the entire bag. And you know that that was given in 30 minutes, and 30 divided by 3 gives you 10 minutes. So I've just divided the amount of the total number of milligrams of sodium chloride in the entire bag, divided that by 3, and then that's given us 1,500 milligrams of sodium chloride in 10 minutes. So if 1% is 1 gram, someone's put a question of if 1% is 1 gram in 100 mils, then wouldn't 0.9% be 0.9 grams? Yes. I'm now confused. Yeah, so that would be 900 milligrams. Yeah, there you go. Tess has done the workings out for me. So that would be 900 milligrams in 100 mil. So it would be 1 milligram in 100 mil. Tess, I need your help. Does that work?
Yeah, I think that works. But also the clue here is in the medication forms under sodium chloride, it says active ingredient sodium chloride.
Yeah.
Ml.
Yeah.
So it's done the maths for you. So I think our maths that I put in the chat is correct. But equally, they've done the maths for you on the BNF, so you don't need to do that.
Exactly. So if you get stuck and if you get confused, if you literally just Google sodium chloride into BNF, it will tell you the amount of the active ingredients. And when you look under medicinal forms, it tells you how much the active ingredient is. So it tells you that 0.9% infusion of saline would give you 9 milligrams per 1 mil. So you don't necessarily always have to remember what the percentage means in terms of concentration of fluids. I'm sorry, I got confuzzled in that section. But yeah, so that is the working out for that, and I hope everyone understood and that I didn't make it 10 times worse for you all. So if we move on, actually before we move on, if any people can pop into the chat their answer for the adverse drug reaction question. So this was the question about what drug was most likely to interact with simvastatin to cause the patient's symptoms. So the options were paracetamol, sodium valproate, colchicine, carbamazepine, or ramipril. What did everyone think? Colchicine. Anyone agree, disagree? No. So we'll move on to the next slide and we'll show the answer. And it was indeed colchicine. So the tip for this question is to just use the interactions checker. So if you click on simvastatin and run through each of the drugs that is offered to you, you're looking for the drug that is either most likely to increase the exposure of simvastatin or cause a risk of rhabdomyolysis, which is the symptom that the patient is experiencing with muscle aches. So when you typed in paracetamol, you would have seen that there is an increased risk of hepatotoxicity. So you could maybe at that point in your answering the question think that the answer potentially might be paracetamol if nothing else gives you a correct answer. With sodium valproate, there was no interaction. When you typed in colchicine, it would have shown a severe interaction that causes rhabdomyolysis. Carbamazepine does the opposite of what you want, so it would have reduced the exposure of simvastatin, and ramipril wouldn't have been an interaction at all. So this is just one of those questions where using the interactions checker, whichever one you prefer, either the BNF or the Medicines Complete, will give you the answer. And you don't necessarily need to remember all of the side effects or interactions of simvastatin by heart. And then moving on to a drug monitoring question. This was the question that asked what side effect would you ask the patient to watch out for. If people can pop it into the chat what they thought was most likely to answer. Oh, and it's there now. Hopefully none of you saw that. Remove it from your minds and put it into the chat. Or even if you did see the answer, then you can put it into the chat. Well, we'll just show what the slide said. So the answer was persistent cough. So when you type in adalimumab into the BNF, and you go straight to the drug monitoring section, which is what I did. And then in that section, there wasn't anything that was relevant to the answers that were offered. I believe it tells you something about monitoring for infection, but nothing quite so specific. And it definitely doesn't mention ESR. And then if you scroll down to the patient and carer advice, the first subsection there is TB, and it advises that we suggest our patients watch out for symptoms of TB that include persistent cough, weight loss, and fever. And persistent cough is one of the options that were offered in that answer. So you know that the answer is persistent cough. There is nothing about weight loss or nausea or vomiting mentioned there, and TB is and the persistent cough answer is the most single best answer there. What were the other options again? Someone has asked. I'll get that for you. So the other options were ESR, nausea and vomiting, number of flares of severe psoriatic arthritis, presence of a persistent cough, or altered mood. And presence of a persistent cough was the single best answer for that question. And there you go. Great. And then moving on to the penultimate, the last question, which is data interpretation. This was the warfarin and high INR question. So does anyone have any suggestions for what the answer to that question might be? And pop it into the chat. Panic and ask hematology. That is what we do in reality. So I alluded to where the answer might be to this question a few times during the presentation, what treatment summary you might find it in. Someone's put A, which is stop warfarin, give IV Vit K. And someone suggested stop warfarin and give all Vit K. And if you move on to the next question, next slide, sorry, we'll see what the answer is. And yes, the answer is stop warfarin and give IV Vit K. And so that's because there is, so the INR, so I've screenshotted what it says on the treatment summary, and this INR guidance is under the treatment summary for oral anticoagulation. So the INR is raised, it's above 8, it's 8.3, and there's some minor bleeding. And so what it says in the BNF is that in this scenario, you would stop warfarin and give vitamin K by slow IV injection. And it says if the INR is still too high after 24 hours, to restart the warfarin when the INR is below 5. So there is your answer. And someone said, where do you find this again in the treatment summary? It's under oral anticoagulation. So again, this is where it's really important to run through the treatment summaries. I don't know if many of you screenshotted where I had put what I had put as the useful treatment summaries, and this would be under one of those. So that is all of our questions done. I hope everyone found that somewhat useful, and thank you very much for listening. Oh, sorry, were you saying something, Tessa? Were you just waving goodbye?
Don't no one use this QR code.
Oh, okay. Do not use this QR code. Ignore it. So just want to say thank you very much for listening. We'll send out some feedback forms. I think they come automatically through Medall. Tell us what you liked, didn't like, if there's anything that we can improve for the next few sessions from our series. And we hope it was useful. In terms of the next few sessions, we'll be running through more specific sections of the PSA, so we'll talk a bit more in detail about prescribing and prescription review, and we'll go into more detail about calculation skills and give you some more example questions to run through and practice on. Thank you, everyone. And then if we scroll a couple of slides down, and then these are our next few sessions. So we have one every Thursday for the next 3 weeks at the same time, same place. And our social media if you wanted to keep following us and seeing what events we have coming up. Thanks, everyone. And yes, please do fill out our feedback form. We really need them for our portfolio. Thank you, everyone. And good luck.
Thanks, everyone.